Hi, Mohammed Al-Mala here. I wanted to show a case of a patient who had intraoperative floppy iris syndrome with iris prolapse and how we manage that. So this is a routine cataract surgery case. We can see the pupil actually dilates quite well. We've made the paracentesis. We're injecting preservative-free lidocaine initially, and we're going to follow that with intracameral epinephrine to help with floppy iris and the history of having used Flomax in the past. And then we're going to inject visco to fill the anterior chamber. We see we really have a very nice dilation here. It looks really quite good. We'll make the main incision, and then we'll proceed with the capsulorhexis. I use a 0.12 forceps here to fixate the globe. I do that for all my cases. It really helps take the stress out of doing the capsulorhexis, and also keeps things nice and controlled for me. So I go in initially with the cystotome. With one continuous motion, we raise the capsulorhexis flap. I go in with the capsulorhexis forceps, and we're going to make a continuous curvilinear capsulorhexis. Things are going really quite smoothly here. Very pleased with how the pupil looks. And really no issues here doing this capsulorhexis. I have started extending my capsulorhexis nasally a little bit. I orient my IOL with the haptics at 3 and 9 o'clock. So I don't need to worry about the capsulorhexis edge overlapping the optic at that location. So complete capsulorhexis, I'm happy with how that looks. And now we're going to go in and do hydrodissection. We'll attempt to get a cortical cleaving hydrodissection here. I do see that little line there, the triangle sign. And we're going to do, oh, okay. So as we're doing that, we see we get iris prolapse. And immediately, what my instinct is to push on the posterior lip of that wound and decompress the anterior chamber. So you can see as I do that, there's viscoelastic coming out of the anterior chamber. And whenever you get iris prolapse, you got to get rid of the mechanism which is causing that, which is the pressure inside the globe is higher than the pressure outside the globe. The iris is floppy, it gets caught in that, and it comes out of the eye. So now that we've thoroughly decompressed the anterior chamber, I can use visco here to push the iris back in. If you try and use visco to push the iris back in while the pressure inside the eye is still high, it is not going to work. You must first decompress the anterior chamber, push on the posterior lip of the wound, let the viscoelastic or BSS is in the anterior chamber come out, and then you can reposit that iris. So this was this patient's way of reminding me that he has floppy iris, and we'll see here as the case progresses, you'll see the iris bouncing back and forth. We're going to do our standard phaco chop technique. I do a horizontal chop here. Very nice rotation in this patient. I found the combination of the cortical cleaving hydrodissection and this phaco chop technique usually results in a very nice nuclear rotation. We're working on the second heminucleus now. We're going to split that up into quadrants. And that actually is going really quite well. That looks good. And now we'll attempt to pick up the first quarter. That looks good, the first quadrant. And we are using the Alcon Centurion here. I'm using a continuous phaco setting in terms of continuous transverse phaco. And we've got the first quadrant out, second quadrant. I'm sorry, torsional phaco. And we're using intelligent phaco. So once we reach occlusion or come close to getting occluded, it gives a burst of longitudinal phaco. So it's a torsional phaco setting with intelligent phaco. Once we get to 90% occlusion, it gives us a burst of longitudinal phaco to help keep the phacomulsification going. So we've gotten 2 quadrants out. We see here we still have 1 heminucleus. It's a large lens, quite dense. And we've prolapsed it into the anterior chamber. And we're just going to take our time here with the phacomulsification and trying to get a good edge of that nuclear material to grasp. And once we grasp it, then it really does come to the tip quite nicely. Very good. One last piece remaining, quite large, and we're going to take our time with it here. Obviously, the more you can split the nucleus manually into smaller pieces, the quicker they can tumble and easier they are to phacoemulsify. Nonetheless, this is going along pretty well. I have my second instrument here protecting the posterior capsule. I've cut down my aspiration flow rate down to about 38. My IOP setting is about 50 or 55, I don't recall, millimeters of mercury. But here we have removed the nucleus and things look pretty good. We do have some remaining cortical material, which we're going to readily remove here with IA. What I just did right there is I irrigated the paracentesis to remove any nuclear pieces that may be floating around in there, and there really wasn't too much. I'm going in now with IA, and this is of course an unedited video. We're watching this in real time, and I see there's a small cortical fragment there, and then I go in and do the cortical cleanup. You can see that some of the cortex is not there. We did remove some of that with the cortical cleaving hydrodissection, but we still have some of the cortex still attached, which is okay. It comes out quite readily. So just a little bit of cleanup here, and then I will probably polish the posterior capsule. This is a Terry squeegee silicone sleeve on this cannula, and I use that to polish or remove any cortical fragments that are still attached to the posterior capsule. Not too much there. Now when I inject Provisc here, I'm going to inject to the right and to the left into the anterior chamber angle. This helps to remove and get rid of any hidden nuclear pieces that may be present. We fill up the capsular bag with Provisc, and then we inject the intraocular lens. This is an Alcon Clarion lens. I use my IA next to center and position the lens, as well as to, once the lens is in good position, I'm sure that the haptics are unfolding properly, then I go ahead and start removing the viscoelastic here. This is Provisc. And then once we've removed the majority of that, then I'll go back into cortex removal mode, which have a little bit more control. The aspiration rate rises more slowly, the vacuum rises more slowly, and I have a little more control of that, and I go behind the lens. We can see the IOL is centered nicely. There is capsular overlap over the edge of the optic. We'll go in and hydrate the main wound first. We want to be careful not to overinflate the anterior chamber so we don't get iris prolapse again in this part of the procedure. So we gently here refill and reform the chamber. The pressure is a little bit high. We're going to test the pressure here just with this cannula. And once we're happy with the pressure, we stop. We check the wounds, make sure that they are watertight. And once we are happy with that, then the case is done. So this is a case of a patient who had iris prolapse. This patient has a history of Flomax. This is intraoperative floppy iris syndrome, but the pupil did stay dilated for the majority of the case. Thank you. I hope you found this useful and helpful to you. Thank you.